And going straight into the topic, we know that paravalvular leaks can interest the mitral and the aortic as well. Mitral leaks are usually more common than aortic, and clinically the patients can experience cardiac failure, hemolysis, or both. Closure of paravalvular leaks is rather demanding procedure. The number of cases in each institution is relatively limited, and the procedure is difficult, even in very experienced hands. That's some large experience reported in literature from Mayo Clinic, and another large experience operator is Carlos Ruiz. But as I said, there is no a huge experience in no institution. We have to understand exactly the morphology, the size, and the impact of the leak that sometimes can be favorable in the sense that it's relatively small, rather rounded, sometimes is large, crescentic shape, is more difficult to close. There are several devices that have been used for closing paravalvular leaks, like ASD device, duct device, VSD, or plugs. That's the issue that can be raised. What is the best device to be used? Well, there is no ideal device to be used. My experience is concerned of just using unplugged vascular plugs, mainly plugs too, actually. More recently, a very small initial experience being reported by these doctors using the new design device for paravalvular leaks closure by Occlutech. I not experienced in this. That's a very, very small experience. The imaging modalities during cancer closure is very important. You use fluoroscopy, angiography, and transesophageal echo, particularly for mitral leaks. Transesophageal echo and 3D reconstruction is paramount importance. My experience consists upon 30 patients with 20 mitral, 10 aortic leaks. That's a transesophageal echo example of an aortic leak. It's rather difficult to see exactly where the leak is. Well, so that is the fluoroscopy and the angiogram in this particular case, who had a paravalvular leak in the aortic prosthesis. The leak is entered with a retrograde way, with the wire placed in the left ventricle, the sheath, and the vascular plug too has been implanted in this case. So you see that's the angiogram immediately after placement of the plug, which is a very nice result with just tiny residual leak, as is seen by transesophageal echo as well as angiography. That's another case with an aortic leak, rather large, I would say. You may guess that's the position and the size, but I would say that in the majority of cases, transesophageal echo is not an excellent modality for assessing aortic paravalvular leaks. That's the angiography that showing, of course, a severe regurgitation, but it's difficult to see where the leak or the leaks are. So you have to make several attempts and do several semi-selective injection in different planes to see where the leaks are. Eventually, we will got that the leaks were there, so the leak is entered, the wire, the sheath, and in this particular case, 2 simultaneous plugs were implanted to achieve a very good result. You see the same patient after plug implantation. You see in the multiplane modalities the 2 plugs placed to close the paravalvular leak. That's another very difficult case with aortic mechanical bioprosthesis that has been implanted by surgery and by patch enlargement of the aortic annulus towards the paravalvular leak. You see this pseudoaneurysm, or whatever you call it. That was the patch enlargement that the surgeon did to put this mechanical valve in. while in the cath lab you see massive aortic regurgitation in different planes. It has been entered 2 leaks, you see. I think that balloon sizing or balloon interrogation sometimes is very, very useful to understand more carefully the many and how many and how large the defects are. And that's the final result, which is rather impressive, taking into account the massive aortic regurgitation you saw before. Another example of a double aortic leak where the 2 leaks were entered by 2 separate catheters, as you see in a second. So the 2 wires, 2 catheters, and of course 2 simultaneous plugs implanted. It is also important to be aware that the device implantation can impinge the movement of the leaflets or the prosthesis, mechanical prosthesis, particularly in the patient when have a single disc. In the double disc, the risk is lower, but we have to take into consideration very carefully. Going back to the mitral leak, this is an example of a severe mitral leak in mechanical bioprosthesis. You see the 3D reconstruction, which is very, very important. I would say the most important imaging modality for treating paravalvular mitral leaks. The LV angiogram showed some regurgitation, severe regurgitation, while you don't know where the dye is going from the left ventricle to left atrium. Where routinely the transeptal technique is used. You see the leak is entered from the arterial side as well, establishing a venous circuit in order to allow the venous sheath from the left atrium to go into the sheath. We attempted to implant 2 simultaneous plugs here, as you see, but it was unsuccessful. There was a significant residual leak. The instability of the patient was remarkable, so we had to abandon the procedure. But this particular patient was a rather hopeless patient, no way to go to surgery. So we decided a couple of weeks later to attempt to close these leaks by a transapical approach. And this is very, very useful actually in most cases of mitral leaks. The leak is entered very, very easily from the sheath that you see was inserted from the apex of the heart and right pointing towards the mitral. This is a very large sheath with 2 simultaneous plugs that are advanced, as you see, partially extruded in the left atrial cavity. Then the entire system is withdrawn under fluoroscopy, and you see the rest of the 2 devices that are deployed simultaneously under echo, transesophageal echo, and fluoroscopic control as well. These are the 2 plugs there, and that's the release of the 2 plugs. There were 2 unplastered vascular plug 3 in this particular case. That was a really huge shunt, and by transapical approach we could close completely this large leak. This is the transesophageal echo pre and post. You see the massive regurgitation that disappeared completely after vascular implantation. Well, that's another example of a smaller mitral leak seen in different planes. Well, Dr. Riyad showed very, very nice examples of 3D reconstruction of the mitral particularly. You see the flow across the leak. Well, the catheterization and the angiography, you see the leak in the inferior part or the mitral prosthesis, and Well, transesophageal echo is also very useful to guide the operator to do the transeptal puncture and to follow the rest of the procedure. The LV is entered from the left atrium. Routinely, we use a steerable sheath that is very, very useful to guide the movement of the telescopic catheter to enter the leak from the left atrium. And this is the plug implantation as seen by fluoroscopy and by 3D reconstruction of transesophageal echo. That's the final angiogram. You see the plug here with no residual shunt. Well, another example of a mitral leak with hemolysis in this particular patient, a bioprosthesis, mitral bioprosthesis with a leak which is pointed by the arrow. Well, in this particular case, for some reason, it was difficult to deploy the plug from the left atrium, so we did in the retrograde fashion from the aorta, left ventricle, left atrium, and we deployed directly an unplatted vascular plug 2 there, as you see on fluoroscopy and transesophageal echo. You see very nicely the movement of the leaflets of the prosthesis and the plug not interfering with the movement. And again, you see before the jet of the mitral leak and then the plug with no residual shunt. Well, this is a peculiar example where we close the mitral leak with a combined approach by transeptal from left atrium. This is the sheet across the leak from the left atrium, a vascular plug implanted. There was a significant residual shunt, so across the circuit that we kept in place, we advanced a catheter, and then from the aorta in the retrograde fashion, the leak was entered by the left ventricle to the left atrium. And as you see in a second, which is the catheter from the left atrium to the left ventricle to the aorta, a coronary guide catheter going to the groin, so we could, over this circuit, advance a catheter from the aorta, left ventricle, left atrium. You see the plug advancing within the catheter. Partially, the LV is deployed in the left atrium now. Then the catheter is withdrawn. The rest of the plug is deployed, jailing with the previously implanted plug. So you have 2 plugs, and that's the final result with a very, very nice position of the 2 plugs there. Well, just to finish with a nice case, interesting case of a 55-year-old patient with congenital retrotransposition VSD, who had VSD repair, then pacemaker implantation, and later on left V1 replacement. And it turned to our attention because of paravalvular leak. Well, this is a transesophageal echo, 2D and 3D of this severe paravalvular leak. In this particular case, you see how complicated was the picture of the heart with a lot of wires, leads, etc. So again, stress the major importance of the 3D reconstruction to guide the procedure. Also in this particular case, 2 simultaneous implantation of 2 unplatted vascular plug 2 were performed, and that's the final result with just a tiny immediate tiny regurgitation with nicely sitting 2 devices, and the patient did very, very well. So transesophageal echo is also very important to establish where there are cases that are not suitable for paravalvular leak closure. In this particular case, of course, you have a severe regurgitation, but looking carefully at the picture, you clearly see a vegetation as well. So, of course, in this particular case, there is surgical indication and not transcatheter procedure. Another occasion when we have to give up or even not to attempt to close the leak when the leak is too large, when you see is more than 1/3 of the total circumference. There is no way that we will be able to close it. So in conclusion, in our experience, the procedure was successful, really successful, in the meaning of trivial or no residual shunt in 20 patients. Surgery was required in 4 out of 30 with 1 surgical death, but significant improvement was obtained in the others. So in conclusion, closure of paravalvular leaks is certainly a challenging procedure. Combined fluoro and echo monitoring is mandatory. 3D transesophageal is essential for mitral leaks, and the best approach in each individual patient from transaortic, transeptal, transapical should be chosen according to the anatomy in each individual patient. So the cooperation among interventionalists, echocardiographer, anesthesiologist is needed. So to achieve good results, a teamwork is really necessary. And I'd like to show an example of a teamwork.
You got a light, mate? Yeah, I have, obviously. Sorry, I finished. So I'll take care of that. I finished. Me too.
Thank you very much for your attention.